My name is Jim Dautel. I am a chiropractor. I've practiced in Clay County, Duval County for the past 25 years. I've been asked by several of the local physicians to help them better understand what it is that we do in our office and some of the procedures that we use. There's sometimes a lot of confusion. Many chiropractors use different procedures from us, and some of them more effective and some of them less. I have found over the past 25 years that an approach that includes a multiple number of different modalities as well as procedures tailored to each patient's needs is what produces the best results. I went to the University of Florida 25 years ago. I went to New York Chiropractic College and have practiced, as I said, in Clay and Duval County for the past 25 years. My practice is primarily back and neck pain oriented, biomechanical spinal joint dysfunction, and the neurological ramifications that are associated with that. We see a lot of patients with disc injuries, degenerative joint disease, facet syndromes, and as you know, these are some of the most common problems that all physicians see in their offices. It's estimated that up to 80% of the American population has significant back pain, significant enough to seek treatment from a physician at some point during their life. Up to 1/3 has back pain on a daily basis. The financial impact of this is catastrophic, estimated at over $1 billion a year. Chiropractors see a lot of these patients with back, musculoskeletal, spinal-related pain. The options for treatment for these patients is somewhat limited. Initially, their usual course of action is a wait and see for several days depending on the severity of their pain. At that point, non-steroidal anti-inflammatories and some rest. When that is ineffective, they begin to seek more aggressive forms of treatment, frequently seen in a chiropractor's office and or a family physician and or a physical therapy facility. Physical therapy is usually directed at exercise regimens, which unfortunately through the acute phases of back pain are frequently too painful to pursue. I have on numerous occasions found that the protocol in many physicians' offices to suggest pain management facilities, which primarily their tool is going to be narcotic medication and or nerve block type procedures, trigger point injections, and in cases where it warrants it, potentially epidural injections. And or if there are radicular symptoms associated with their back pain, frequently they're directed to a neurosurgeon and an MRI facility. The MRI facility is certainly appropriate when there's back pain, including neurological complications. However, initially, MRI scans frequently can be misleading. It's been estimated that many of the MRI scans performed are unnecessary or premature, in that most back pain can be resolved conservatively, up to 90% of it. Neurosurgery is only warranted in 1 or 2% of the cases, and those are usually associated with Cauda-Equina syndrome. Frequently MRI scans are misleading because even healthy MRI scans frequently show disc lesions, significant degenerative changes, and these may not in fact be the cause of the patient's present back pain issues and may lead to unjustified, more aggressive procedures than necessary. William Lauderdance reported in the Journal of Neurosurgery and Neurology in April of 2001 that through the review of literature, he found that there was very little efficacy for spinal injections, particularly epidurals, and significant dangers, including arachnoiditis, potential infections, and the outcomes were short-term and produced no long-term significant benefit as far as relieving either sciatica and or back pain. As I mentioned earlier, only 1 to 2% of the cases of back pain are appropriate for neurosurgery, and the options other than neurosurgery and pain management facilities, as I mentioned, are physical therapy and or chiropractic physical medicine modalities. The procedure that I use in my office most frequently is a flexion distraction procedure developed by Dr. James Cox. I've been using this procedure for over 25 years, and shortly we will move into one of the treatment rooms where I can demonstrate the equipment. I have also more recently been involved in the investigation of spinal decompression equipment. Flexion distraction is a manual form of spinal decompression. We have recently included in our treatment armamentarium a Accuspina device that is a computer-driven, much more significant, sophisticated type of treatment, and we will visit the treatment room and have an opportunity to see that type of equipment in action. So at this point, we're going to take a short break, and I'm going to move into one of the treatment rooms where we can take a look at the flexion distraction equipment, which is a mobilization decompression process that is manual in nature. This is a flexion distraction table. It's a device that I've used over the past 20 years. This is the most recent model that's been put out. Dr. Cox is the developer of this. It actually was used prior to his input by osteopathic physicians. The table at that point was quite a bit different than it is now, but the principle was the same. Essentially, we can treat both neck and lower back problems with this table. This is where I usually bring patients that are what we consider mild to moderate episode of back pain, and the process is to mobilize and decompress, take the pressure off the spinal joints. The caudal piece, the lower piece, actually moves in multiple directions, multiple planes, right, left, lateral flexion, as well as flexion. As a patient is being treated on this table, they lay prone. I contact the level above where they're having difficulty, use their leg for a lever, lower the caudal piece of the table, creating a traction force in the joints that are affected, allowing us to get to where the pressure's decreased and mobilize the soft tissue that supports that joint in both the flexion direction, lateral flexion, and we can combine the two to get a circumduction type movement to reestablish normal range of motion. The decompression component of this is very significant. We can take a intradiscal pressure from its normal of 75 millimeters mercury pressure in a prone position down to about 100 millimeters negative pressure, which allows the disc to reestablish a more significant diffusion gradient, allowing us to pull and push fluid in and out of the disc the way that it's meant to, which is the way the disc is primarily nourished. It's been estimated that 80% of the patients with low back pain have some disc-related portion of their back pain. Annular tears, protrusions, prolapses, sequestered discs. It's difficult frequently to separate out disc patients from patients with facet syndromes, in that frequently there's a combination of issues, particularly with degenerative disc disease. As the disc loses height and becomes more rigid, it frequently stresses the facet joints, which, if allowed to progress long enough, eventually leads to stenosis of both the ligamentous osseous canal, the neuroforamina, as well as the central canal. Compromising the neurological structures. We've had great success in decompressing foraminal stenosis, central stenosis to some degree, but that's more difficult with this equipment. and we're having much better success with the more sophisticated spinal decompression Acuspina system, which I will visit very shortly. This table is automated to some degree. The caudal section can be used as an axial traction device, and you can combine that axial traction with the lateral flexion and flexion components. We also treat neck patients on this device, and it's more of a mobilization process, but there's also a traction component to it. Manual in nature, the headpiece moves in multiple vectors. Flexion, extension, as well as rotation. And so we can mobilize cervical spine joints similarly to the process for lower back joint. Manual process, contacting the level involved and using the table to allow us to create a traction force and mobilize joints in the direction that's tolerable and necessary to reestablish normal movement. This has proven to be very effective for many patients with degenerative disc disease. Many chiropractors utilize a more manual manipulative type procedure with these patients. I've found over the years that that can be too aggressive, traumatic, and this type of procedure is tolerated much better. At this point, I'm going to move once more to where we have our spinal decompression equipment and give you an opportunity to see how that equipment operates and the software that drives it. We've moved now into the treatment room where we use the Acuspina spinal decompression equipment. This equipment was developed by pain management specialist Norman Shealy. It's been in use for approximately the past 5 years. Its predecessor was known as a DRS, spinal decompression unit. It's gone through the process of evolution. This is the 5th series and the most advanced, in that the goal is to create a spinal decompression force. The equipment prior to this had many different components that have now been updated to produce a more effective treatment protocol. The older equipment was designed to have the patient lying prone, and the patient actually had to hold on in order to create a traction force with their hands. The traction force had to be transmitted all the way from their hands down through their shoulder girdles into their spine to get to the level of the lumbar spine, which is where this treatment is directed. As I had mentioned before, up to 80% of back patients are estimated to have disc pain as their primary issue. The disc itself, the annulus and the nucleus. The annulus is well endowed with pain receptors, and the annulus itself can be an issue with back pain, particularly degenerative back pain patients. To some degree, annular tears without protrusion or prolapse, and the obvious protrusion prolapse where the nuclear material has shifted up against the annulus, creating a deformity in the outer covering, causing a nerve compression syndrome. The goal of this equipment is to create a negative intradiscal pressure, which it has been proven to decrease intradiscal pressure from a supine or prone position of approximately 50 to 75 millimeters of mercury down to as low as 175 millimeters of mercury negative pressure. That negative pressure allows for a reestablishment of the normal diffusion process from the extradiscal fluids to the intradiscal fluids, which is paramount in establishing the normal flow of nutrients from in the disc to from the external fluids, as well as reestablish normal nuclear position. The negative pressure creates a suction type force, which actually has been proven pre and post MRI scans to decrease disc protrusions dramatically. This patient is undergoing the treatment right now, and as you can see, the treatment is comfortable enough that she is right now asleep. The positioning is something that's very important. This position allows us to decrease the lumbar lordosis by keeping the knees bent and the pelvis slightly flexed. We can determine the level of disc, the spinal level that we want to treat by the angulation of the traction force. There is a thoracic harness as well as a pelvic harness. The pelvic harness stabilizes the pelvis to create the traction force, and the thoracic harness stabilizes the rib cage so that the traction force is focused on the lumbar spine. If we can move toward the computer screen, this is the brain of the system, and we can control the force of the traction, the parameters that the traction is applied with from a multitude of different parameters. Obviously treatment time, the high tension, the progression time, in other words the slope of the application of the traction force, the regression time. So for an acute patient, it's frequently necessary to change the intensity of the onset of the traction force so that it's much more gradual. This patient has been treated approximately 15 times in the past. She's doing very well. We have gradually increased the rate of the application of traction so that we can get more repetitions of the traction relaxation phase in each treatment. If you can see the blue line as well as the red line is the actual application of the traction. The computer continuously talks with the table, receives feedback as far as what force is actually being applied, and continuously tries to produce as close to the desired protocol as possible. There is an oscillatory wave at the top of the traction force that's applied in each cycle. The angle of the traction force helps establish which level in the lumbar spine treatment is directed at. The outcomes with this table are an 86 to 90% satisfactory outcome, which satisfactory outcome for us is a 50% decrease in symptoms and or increase in physical capacity. Frequently, the majority of patients recover much more significantly than 50%, 80 to 90%. We've had very good results with patients that have been pre and post MRI with reduced disc protrusions. We've had multiple patients that have been told they required surgery that have been able to avoid surgery. This device also has an application for cervical spine pain. There is another component that attaches to the headpiece of the table that we can apply a cervical traction driven by the same computer system with the same waveform type application of the traction force. The cervical component has only been in use for the past 2 years, very good initial outcomes. The lumbar device has been in use for the past 5 years, and as I said, 80 to 90% success rate. We only use this device with patients that we categorize as moderate to severe, that have failed other procedures, have failed pain management, have been prescribed neurosurgical intervention, or post-MRI with disc herniations. We will frequently use a short course of trial treatment on the Cox flexion distraction equipment If we don't see the results we want in the first 10 treatments, if we don't feel as though we're making satisfactory progress, we discuss the option and the possibility of moving to the more intense type of treatment program. The protocol for the Acuspina equipment is to see the patient 4 times a week for 5 weeks. At that point, they should have reached a point of maximum medical improvement. We will sometimes go for another week, and in rare instances go for a 6th week, but we have never exceeded 6 weeks in treatment, and the studies of long-term outcomes do indicate that many patients continue to improve as much as 1 year post-treatment, due to the fact that the diffusion gradient of the disc has been altered back to a more normal level of intradiscal pressure and allows the healing process to continue. And so a significant number of patients feel as though they have continued to improve even after treatment has been completed for up to a year post-treatment. I hope that I've answered some of your questions. I hope that this makes things more clear as far as what we have to offer in the treatment of back and neck pain. All too often physicians have been under the impression that the only procedure that we use is manual spinal manipulation. We have found that for most disc patients, the manual type of manipulation is too aggressive and is unwarranted. With some of the degenerative, less severe patients, it can be very effective. However, the availability of having manual manipulation plus the physiological therapeutic devices that we use in addition to that, we do have several neuromuscular massage therapists that work with us, and the flexion distraction equipment, and now more recently the addition of the spinal decompression equipment has proven to be a very effective combination. I'd be more than happy to discuss any of this with you at length. I have found in the past that it's frequently difficult to coordinate times when it's convenient for our busy schedules to be able to have an opportunity to talk individually, and so that's why I have decided to produce this very amateur videotape, but I hope that it has allowed me to communicate with you at a time when it's convenient for you and give you the information that I think is important for your patients. Thank you.